All right, here we go. Okay, so this is Dr. Mike Robich. For those who don't know, he's an MMC cardiothoracic surgeon, and he has been awarded today a Faculty and Scientific Talk Award. His is the Award for Excellence in Quality Improvement Research, and he will be presenting a comparison of intraoperative tranexamic acid and epsilon amino caproic acid in cardiopulmonary bypass patients, a natural experience.
All right. Thank you very much for that nice introduction, and appreciate being here and the opportunity to present on behalf of a number of our researchers, including Dr. Bob Kramer, who's here today. So yeah, this is a study that was sort of interesting, and looking at some of the agents that we use in heart surgery to prevent bleeding. I have no disclosures related to this presentation. So in cardiac surgery, we oftentimes give antifibrinolytic agents to patients undergoing cardiopulmonary bypass to reduce bleeding. And one of the classic agents that we used for a long time was a drug called trazolol, or aprotenin, which was removed from the market in 2008 for kidney injury and increased mortality. And so that left us sort of with these two drugs left, called tranexamic acid is one of them, and then aminocaproic acid, or aprotenin, which is the other. And these two drugs are now sort of the ones that cardiac surgeons have been using. And this slide will probably prove to be the most popular of the afternoon. I'm sure everybody enjoys looking at the coagulation cascade. But just to show how these drugs work, TXA and Amicar work here by blocking plasminogen conversion to plasmin, and then ultimately in breakdown of fibrin. And so we use these drugs, they're around. But in 2011, and this is probably a story that's familiar to a lot of folks for a lot of reasons, Amicar went on shortage. And due to different reasons, manufacturing delays and other issues, Amicar wasn't really available anymore. And so this provided sort of the impetus to force us to change essentially from one drug to another and use that. So TXA is a drug that's given. We give it as a loading dose before surgery, and then depending on the creatinine level, they get a maintenance dose throughout. Amicar also has a loading dose that's given before surgery, and then given at the start of the cardiopulmonary bypass run as well. And so the cost of these drugs, essentially not that different, about $5 different. TXA is a little more expensive, but not much more for us to use them. So from that standpoint, it wasn't a huge deal. And so really what this study looked at was the use of TXA and then Amicar. And so we looked at basically a year's worth of cardiac operations that utilized cardiopulmonary bypass for each of these. And these were sort of consecutive years when we looked at it. So a lot of things didn't change. You know, the surgeons who were operating were not significantly different. And there was no other major changes that went on. For this, we excluded patients who were less than 18 years of age, anybody who was not done with cardiopulmonary bypass support, if an antifibrinolytic wasn't administered for whatever reason, and patients who had a history of coagulation disorder, whether it was a primary coagulation disorder or if it was liver disease or some uncontrolled cancer or something like that, they were excluded. And our primary outcomes included hospital mortality, stroke, acute kidney injury, postoperative chest tube output in the first 24 hours after surgery, what blood products were given, and seizures. Secondary outcomes included postoperative length of stay, intensive care unit length of stay, time on the ventilator, and then hospital charges. So we look back at 1,773 patients who underwent operations. 159 were excluded. That left us just over 1,600 patients that were included in the comparison. This included a bit over 800 who received TXA and a bit under 800 who received the aprotenin, or the Amicar, sorry. So really, these groups were fairly well matched. There were not a lot of differences between the groups. Age, gender, diabetes, starting hematocrit, starting platelets, previous cardiac surgery. One thing that was different was Plavix. Patients who received Plavix within 5 days of surgery was higher in the TXA group. The procedures that the patients underwent were also not significantly different. Isolated CABG, bypass operation was the most common, valve, and then bypass and valve, and then a miscellaneous host of other things. So I have the crude effect here, and highlighted in yellow, though, is the adjusted. We did adjust for Plavix use in previous cardiac surgery among the group, and there was no difference between TXA and Amicar in mortality, in stroke, in acute kidney injury, or reoperation for bleeding. And we'll show this in a more visually appealing way in a minute, but when we look at transfusion, those that received the TXA were less likely to receive any blood transfusion or any transfusion of blood products, less likely to receive platelets. Intraoperatively, they were less likely to receive platelets, and postoperatively, less likely to receive any transfusion of blood products or red blood cells. The folks who did receive TXA were at a higher risk to be on vasopressor support 48 hours after surgery. So again, this is just showing this in a different way, but we can see here that overall transfusions odds ratios was favored TXA for any product transfusion, and platelets. Red blood cells were close but did touch the referent. Intraoperative transfusion, much significantly lower with platelet transfusion, favoring TXA. And then postoperatively, less likely to receive any blood product transfusion and also less likely to receive red blood cells. And so when we look at the continuous variables post-op, and this is interesting, we'll kind of show this in a second, but post-operative length of stay was less for TXA. No difference in ICU length of stay. Post-operative ventilator time was lower with TXA. Chest tube drainage was no different between the two. And then charges, even though TXA costs about $5 more per dose, the patients had $30,000 or $3,000 less in hospital charges with the use of TXA. And so when we look at this, the medians for the Amicar and TXA were pretty much the same, but the distribution isn't quite. There's more outliers in the Amicar group. The same was seen for postoperative ventilation time, and then post-surgical charges also. You can see that there's more outliers towards the high end of the spectrum on our charges. So in summary, the tranexamic acid result in less transfusion, less postoperative ventilator time, shorter ICU and postoperative length of stays, lower charges with no increase in mortality, stroke, reoperation for bleeding, acute kidney injury, or seizures. And so from this work, we felt that TXA, when compared with Amicar, would be the ideal choice for an antifibrinolytic agent during cardiac surgery with cardiopulmonary bypass. Thank you very much.
Mike, that was a great talk. Thanks. one question I have is that the way the study broke down was that the TXA was used in sort of a later era, right?
Mhm.
Because it was basically when Amicar was no longer available. Is that right?
We were using so after yes. Wait, you're asking about Amicar and so here TXA was the earlier era, was 2013 to 2014, and Amicar was the later era 2014 to 2015.
Right. So could it be that it has to do with difference in surgeon preferences, or did you look at by surgeon practices in terms of were there certain surgeons who would had different transfusion practices or thresholds?
Right. Yes, Sunil, that's an excellent question, and that's always something that's there certainly were transfusion preferences and things like that. The only way that we can kind of control for that in that study is that the surgeons didn't change over these 2 periods of time. They were the same surgeons, so we sort of make the assumption that they had the same preferences at the beginning and the end, although that may not hold true. But as far as which agent to use, that was the surgeons weren't and still aren't sort of deciding which antifibrinolytic agent we use. We just use what's available,
right?
And what the pharmacy has.
And were you able to break out the reduced sternotomy patients, and if what effect there was there not enough?
Yeah, so we ended up controlling for that because previous cardiac surgery was low in each group, 7.3 in the Amicar group, 5.4 in the tranexamic acid group, and so they weren't different. We ended up controlling for that in the adjusted variables.
I guess I was wondering if it would be interesting to see in that patient subset,
yes,
what the impact of each of the antifibrinolytics was on transfusions.
Yeah, I think that's reasonable. There has been, anecdotally, when we switched in Cleveland at this time, didn't make any difference. We were really worried about. Everybody was worried about the redos, but it didn't change anything. Didn't change transfusion. Minimally changed chest tube outputs. So I think that's exactly the sort of the one you want to go to. What it does with primary operations is less, but with the redos, I think is where we are more concerned about it. But I don't think it. But no, we didn't. With the small numbers that we had here, we didn't look at that, but we could potentially pull that out.
Yeah. And did you include like dissections and emergent operations that could be? Were those patients included as well?
Yes, I think for this one we left all those in there. So yeah, absolutely. So I think I shouldn't say that we could do that. We should do that. We should look at redos specifically. I think that would be important.
Yeah.
As we write up this manuscript, I think that's something that people are going to want to know about.
Yeah. Congrats, Mike. Great talk.
Thanks, Neil. Appreciate it.
Great talk. Thank you. The question I have is, do you know the numbers? Oh, sorry, it's not on. What sort of platelet count and hemoglobin count were these patients being transfused for?
Yeah.
Year to year. Is there that, and I'm just thinking about that in regards to the change in practice patterns for transfusion thresholds.
That's exactly right, and then it's that's always tough to pin down because the fact is, I think as Sunil was alluding to, different surgeons have different thresholds for when they transfuse people, and it'll be different. I don't think any of us walk around and say we transfuse at this level for everybody. Maybe something would happen and you'd change your transfusion threshold based on the patient, whether they have a kidney injury, acute or chronic, whether they've had previous stroke, whether they have COPD. So again, the surgeons certainly had different thresholds here, and we don't know. So we can't say, no, we don't, why they did or why they didn't. But that's been a huge thing. I mean, recently with the TRIX trial coming out, almost all cardiac surgeons walked around saying, geez, we're going to transfuse older people because they're older and they need blood and they need, all this stuff. And that trial just turned that all upside down. And the fact is they do worse, just like everybody else does if we transfuse them. So that's a good question.
Mike, very exciting data. A couple of questions. Did you, by any chance, check the occurrence of edema in the patients and the effect of TXA versus ECA?
No, that's a good question, though, and we could probably do that if we took their dry weight right before surgery and compared that to their, let's say, post-operative day 2 or 3 standing scale weight, because the assumption would be that the weight that's gained would be fluid gain. We did not do that. We could do that. Are you thinking sort of along the endotheliopathy? Yeah, tell me what you think about that. How would that be an accurate enough?
Well, it's the closest kind of relations to what you can see. Any kind of kidney difference? You didn't see anything.
No difference in acute kidney injury.
And how about any cases of kind of inflammation, systemic inflammation cases, so you can monitor this?
That's difficult for us to pull out clinically. Now, one thing that's sort of interesting is this on the bottom 2 rows on this table are that the patients who received TXA were more likely to be on pressors 48 hours after their surgery, meaning that either they had some inflammatory thing going on that caused them to be vasoplegic or to have a lower blood pressure due to decreased vasomotor control. It's hard to say. And I think what we're talking about is that tranexamic acid, there's some suggestion that it's involved with endotheliopathy, which controls a whole lot of things downstream in relation to damage-associated molecular proteins and things like that. So we're trying to sort that out. And I think somehow bridging the clinical information that we're able to get to these molecular findings that are out there is interesting. But I think edema would be one that we definitely could look at by looking at weight differences to see if there's any difference between the groups. Inflammation is challenging, though. We just don't, we can look at white blood cell count and some other sort of very crude ways of understanding inflammation, but generally we don't have good ways to look at that. Yeah. All right, thank you.
All right.